As Dr. Tapas rightly said, it's something what we consider as a special consideration, or patients where we see acute kidney injury, and patient who, the people who are practicing in obstetrics or obstetric critical care definitely see patients with acute kidney injury in their ICU, and sometimes we have to start renal replacement therapy for these patients. But unfortunately, there are no much evidence, and why there is no much evidence, I will be talking why there is a lack of evidence, I should say, and most importantly, why there are trials which are lacking, especially looking at renal replacement therapy in pregnancy. So I'll be talking both aspects related to this special population. I will keep my video off so that my connection stays stable. I hope. Yeah, if it allows, it's okay. Let's see. Okay, so when we say renal and acute kidney injury in pregnancy, we need to know there are definitely physiological changes which happen in a pregnancy into almost every organ of the body, and most of these organs are affected by predominantly the hormone effects, which are progesterone and estrogen, but also because of compensatory changes in the major two organs, which are heart and lung, and that leads to increase in cardiac output. So there is well-known increase in cardiac output in patients with, in pregnant patients, and that leads to increase in renal blood flow. As Professor Marley has rightly pointed out, kidney is one of the most vascular organs we have in the body, and with 20% of the normal cardiac output going in a non-pregnant female, here the cardiac output increases up to 30 to 40%, especially between the second and third trimester. So there is proportionate increase in the blood flow by almost 70 to 80% in a pregnant woman, and nearly to the start of the third trimester. Besides that, there is also an increase in glomerular filtration rate. So there is an increased renal blood flow, there is an increased GFR by almost 50%, and there is a tubular function which gets deranged. So the handling of tubules, of electrolytes and water get deranged. And because of that, there is a glycosuria which is happening in the pregnant woman. There is a calciuria, so there are loss of electrolytes, and there is a bicarbonate loss in the urine that leads to loss of the normal bicarbonate of around 16 to 20. But there is no much acidosis which happen in these patients. That is also partially because there is an increase in respiratory rate. So there is a respiratory alkalosis which is get partially compensated by this so-called bicarbonate loss because of tubular mishandling and the compensation of that respiratory alkalosis. So there is no acid-base disturbance, but there is a low bicarbonate which is normally seen in a pregnant woman. Besides that, the threshold to release of antidiuretic hormone is depressed. Because of that, there is a dilutional hyponatremia. So a sodium of between 130 to 135 is commonly seen in patients who are pregnant. And also there is loss of sodium in the urine because of antidiuretic hormone, which is the threshold for ADH release is depressed. Also, there is compensatory, the potassium still remains in the normal range because of the progesterone effect. The plasma osmolarity goes down, and 270 to 275 is the normal plasma osmolarity which we see in a pregnant woman. Besides, there are endocrine, functions like increase in renin and erythropoietin, which are not much common as such when we see patients in our ICU, but definitely the cardiac output and compensatory increase in renal blood flow. There were also increase in GFR, which is very much important. And because of this increase in GFR, what you see is a decrease in urea, creatinine, and obviously uric acid. So a normal serum creatinine of 0.5 is something which we normally see in pregnant women. Increase in serum creatinine above 0.8 is a patient who has definitely at risk of going into stage 1 AKI. So a normal serum creatinine, which we normally take for a normal non-pregnant woman, is around 1. But here, anything above 0.8 is abnormal and needs a further investigation. Definitely, it doesn't mean that a patient has already developed acute kidney injury, because we have to see the other baseline parameters. But yes, creatinine, an isolated creatinine of 0.8 and above, needs further investigation to identify such patients going into acute kidney injury. Now, we are now familiar with these classifications, which are there in any other non-pregnant human being, rifle classification and AKIN or KIDGO. So these have become standard of care now to classify acute kidney injury into intensive care unit or even out of intensive care unit. Unfortunately, if you look at these classifications, especially the first stage, which is risk, is maybe missed in these patients because of pre-physiological changes in the creatinine, because they are still dependent on the creatinine value. So if you are looking at isolated creatinine value, there are high chances that you may miss the start of acute kidney injury in these patients, because the baseline is definitely shifted on the left, and because of that, an abnormal increase in serum creatinine may be missed, especially in the stage 1 kidney, unless they have progressed to higher stages. And that's the reason most of the trials have either excluded these patients, or even if they have included these patients, they have not been clearly the modified criteria of these AKIN and KIDNGO has not been taken into these trials for consideration. So we really do not know, even if the patients have been included in some of these trials, they actually reflect the patients who are stage 1 or stage 2 kidney as real patients who are at pregnant women developing an acute kidney injury. So it's the problem of missing up these patients, especially in the initial phases, and definitely exclusion of these patients in the most of the trials of therapeutic, whether renal different doses or timing of the renal replacement therapy. So we will be talking about that. Now, what are the causes of acute kidney injury in pregnancy? So there are causes which are definitely as like a non-pregnant woman, as what we see in pre-renal causes, like patients who are developing a hypovolemia due to any cause, a renal or an extra-renal causes, or an hemorrhage or hemorrhagic shock, patients with sepsis because of a systemic disease, like a congestive heart failure or sepsis, ultimately developing acute kidney injury, or there could be post-renal causes, at what we see in in a non-pregnant woman, a mechanical obstruction because of a stone, or somewhere abnormality in the urinary bladder. So those things like PU junction wall. So all these will be still valid for a patients with pregnancy. But besides that, there are specific causes which could be related to pregnancy itself, and we need to identify these causes separately. So there are the usual causes of acute kidney injury, and then there are pregnancy-related acute kidney injury, which can happen because at the different trimester, maybe in the first trimester, it's the hyperemesis gravidarum itself, or sepsis because of either missed or septic abortion in second trimester, where we especially talking about 20 weeks of pregnancy, where preeclampsia and eclampsia, one of the most common cause of pregnancy-related acute kidney injury, starts taking a shape. And by the third trimester, it's again these thrombotic angiopathies like using TTP or like TTP-HUS or HELP syndrome may also contribute to acute kidney injury. Besides that, acute glomerulonephritis, some of the glomerulonephritis may precipitate during pregnancy, though there is no much separate data which has been done in pregnancy, but there are some glomerulonephritis which may precipitate itself during the pregnancy, again may contribute to pregnancy-related acute kidney injury. And then postpartum, it's predominantly the hemorrhage, which is the common cause besides the sepsis, which can contribute to acute kidney injury in these patients. Now, talking about pregnancy-related acute kidney injury, further the incidence, as we see, the predominant the causes is preeclampsia and HELP syndrome, and in developing world, in the lower income and lower middle income countries, the puerperal sepsis. So if we talk about the developed world or talk about the high income countries, preeclampsia HELP syndrome is the predominant cause, and then followed by like TTP and HUS. While in predominantly in the developing nations or in the lower income group of countries or lower middle income group of countries, still sepsis, puerperal sepsis especially, is the predominant cause of pregnancy-related acute kidney injury. Talking about preeclampsia, I think one of the very well studied topic. There has been extensive investigation now, which has been done, especially the preeclampsia and pregnancy-related acute kidney injury. And this particular study, which was published in American Heart Association journal, that AHA journal, so circulation journal, where they found that almost 15% of the patients with preeclampsia ultimately develop acute kidney injury. And what they found was there was increased risk of maternal mortality, increased risk of perinatal mortality, and requirement of ICU admission. Besides that, they found that hypertension itself is one of the strongest predictor of acute kidney injury developing in pregnant women. So preeclampsia is one of the predominant cause which can develop pregnancy-related acute kidney injury in these group of patients. Now, why this happen? And again, as I said, this is one of the most studied aspect, crosstalk which happens between the placenta and kidney, and that's the reason preeclampsia may induce a permanent kidney damage. So it's not only these patients may develop acute kidney injury, these are also the patients who may have persistent renal dysfunction for long because of these crosstalk which happen between placenta and from the kidney to the placenta, where it may cause the chronic kidney disease may itself cause placental dysfunction with increased risk of hypertensive disorders of the pregnancy. So it's not only patients who will develop preeclampsia will develop acute kidney injury, but also the patients who have chronic kidney disease are more likely to have placental dysfunction, they are more likely to have, preterm delivery and may have higher risk of developing a preeclampsia. So it's a crosstalk which happens between, especially because of this, vascular nature, and that what contributes to, organ dysfunction, which is interacting between the two organs. Now, talking about the outcomes, again, this is one aspect which has been studied into various type of, observational and even a meta-analysis which was published in BMC Pregnancy in 2017. But they found was pregnancy-related acute kidney injury has very high risk of requirement of cesarean or developing a puerperal hemorrhage. What they also found was the risk of HELLP syndrome and complication related to the pregnancy like placental abruptio or DIC also definitely increases significantly because of acute kidney injury. The patient require higher rate of ICU stay. Again, not just the maternal outcomes which worsen, but also the fetal outcomes like increased risk of stillbirth or perinatal death, higher rate of, smaller gestational age babies delivery, higher rate of lower birth rate, deliveries, which are common in these patients. And the patient who requiring dialysis in women was almost 2.4%. So the patient who developed from these acute kidney injury into end stage renal disease was around 2.4%. So there is a significant contribution to even, prolonged renal dysfunction in these patients if they develop acute kidney injury. What about specifically the mortality? There is increased risk of both mortality and fetal mortality of almost 5-fold, which has been seen with preeclampsia and especially patient who develop pregnancy-related acute kidney injury. So talking about, the management of acute kidney. So we saw that patient of pregnancy, especially developing a preeclampsia or severe preeclampsia, are at higher risk of developing acute kidney injury. And definitely these are the patients which will have a higher maternal and, fetal morbidity and mortality. So when we talk about maternal and fetal morbidity and mortality, so now we are understanding it's not only the maternal, what we have to manage, but also the two lives which are going to be part of this management. So most of the therapies and most of the renal replacement therapies or other therapies consider not just the maternal, but also the fetal aspect. So the current, as the Professor Marley said, there is no specific therapies which are available for acute kidney injury. The same applies for these group of patients. It's the treatment of the underlying cause, supportive management, which are mostly taken care of in the consideration of the fluid and electrolytes, and finally the renal replacement therapy if the patient actually requires some sort of dialysis or a continuous mode of renal replacement therapy. So what is the evidence or what is the data which is there in renal replacement therapy in pregnancy? Unfortunately, the data is very, very sparse and of very poor quality. Most of the data has been actually extrapolated from CKD patients who decided to go for a pregnancy or became pregnant and continued on hemodialysis. So most of the data has actually been extrapolated from these group of patients rather than the patients who primarily develop acute kidney injury into the during the pregnancy and require renal replacement therapy. And most of the trials, as I said, did not use the standard definition or they were not modified for these group of patients, and that's the reason we lack actually good quality data for these patients. Moreover, thrombotic microangiopathy, a common cause of pregnancy-related acute kidney injury, are excluded in most of these trials. So we do not know how is the outcome or when to use renal replacement therapy for especially thrombotic microangiopathy, as what we have seen in higher income countries, especially after severe preeclampsia. It's one of the predominant cause of acute kidney injury in these patients. Finally, the management outlines is either a consensus based or extrapolated from non-pregnant women, and that's what we will be seeing in next few slides. So talking about targeted therapy, I think it's the most predominant group wherever we have possibility, like in patients with severe eclampsia, termination of pregnancy itself is one of the therapeutic action what you can do. So early termination, and as sometimes an urgent termination of the pregnancy is required, which can treat the basic pathophysiology. So severe preeclampsia and HELLP is the where termination of pregnancy should be considered besides the acute fatty liver of pregnancy. For acute glomerulonephritis, it's the immunosuppression, which is as what we see even in the non-pregnant women. So that has to be considered, considering the maternal life first. Anticoagulation for antiphospholipid syndrome, if that is the reason for acute kidney injury. Plasma exchange therapy, plasmapheresis is an established therapy for thrombotic thrombocytopenic purpura (TTP). But for HUS, it will be complement therapy because plasma exchange therapy does not have found to be much benefit in these group of patients. So these are the specific therapy which we should consider as what we will be considering even in the non-pregnant women. But yes, termination of pregnancy definitely only in patients with HELLP syndrome or severe preeclampsia and acute fatty liver of pregnancy. Now, this is the one, we recently reviewed and has been published as a book chapter in this year, and the book is available now. I will recommend that, where me and my colleague Devin have actually reviewed the evidence, whatever is available on renal replacement therapy in pregnancy. And book is now available on Amazon and ISCCM website, besides the JP, which is the publisher. So the indications primarily is basically taken from a non-pregnant woman, but as I said, the data has also been extrapolated from the patients who require hemodialysis because of chronic kidney disease and became pregnant. In the literature, the indications are the conventional indications, where threefold rise in serum creatinine or urine output dropping by 0.3 ml per kg per hour for more than 24 hours, rifle classification of stage 3 or stage 4, and then finally refractory hyperkalemia, intractable fluid overload, or acidosis. So these are the conventional indications. But whether we can actually wait to these life-threatening or potential indications, or do we need to consider renal replacement therapy, especially in acute kidney injury patients, into ICU? That is still under a debate. And when we talk about the chronic kidney disease patients who coming sometime into ICU because of either severe preeclampsia or have been part of some other reason, maybe because of peripheral sepsis, come into your ICU, the management is different. As I said, the renal physiological changes need to be considered. So low bicarbonate is really normal for these patients. So one should not try to correct that low bicarbonate because of oxyhemoglobin curve, which will shift, and that may lead to fetal compromise. So lower bicarbonate is acceptable. A calcium range of around 2.45 millimole is acceptable for these patients. Low flux dialysis, and basically high protein diet. It's a conventional hemodialysis prescription which is valid for these patients, and that has to be considered also while patient coming into ICU. Now, coming to the other modality of renal replacement therapy, talking about the timing. We know in non-pregnant women, there is an ongoing debate between early and late, and I think Dr. Herschel was really describing that. Definitely, we should not wait till it is too late, but definitely consideration between early and late. Talking about maternal purely, there is no difference in outcome, and the studies have also been, at least 2 major observational studies have found there is no difference of maternal outcomes when renal replacement therapy was started early or late. But what was most important was looking at the perinatal outcomes. What they found was when you could reduce urea to a critical level of less than 40 in these patients, the perinatal outcomes were better, and that's why delaying renal replacement therapy in patients with pregnancy-related acute kidney injury can be harmful for the fetus. May not change the outcome for the maternal, but definitely could be harmful for the perinatal outcomes. And the same has also been found in patients with chronic kidney disease who are going on dialysis. So higher intensity of the therapy and maybe early initiation of therapy has been found useful in these patients as compared to what we see in a non-pregnant woman. Coming to the dose, as I said, it's not only the timing, the frequency, I should say, the dosing, which is also been found effective, looking at the perinatal outcomes. The same way as we see that in a maternal outcomes, there may be not much difference, both in mortality or in length of stay, but in perinatal outcomes, the studies have found, and not just one study, there have been a meta-analysis where they found, again, these were the patients who were on chronic kidney disease going on maintenance hemodialysis. They found with increasing intensity and frequency, there was a better perinatal outcomes. Though the randomized studies are not available looking at specifically a continuous or a intermittent renal replacement therapy for patients with acute kidney injury, but the data which has been extrapolated from a chronic kidney disease, definitely so there is a better perinatal outcomes if the intensity is higher or frequency is more in these patients as compared to what we normally do in a non-pregnant woman. Talking about the modality, there is no difference as what we have studied from most of the trials which have been done in non-pregnant. So it's still an ongoing debate. Again, the choice of therapy will be decided by the disease, as what Dr. Herschel was saying, the disease burden per se, the patient preference, and sometimes the target what you want to achieve. Again, a continuous versus an intermittent will be decided depending upon the person, depending upon the patient, and the availability of those therapies and resources in your facility. So at present, there is no much evidence to choose which one above the other. So it has to be decided, or it has to be personalized. Talking about anticoagulation, I think as what we see, there are renal changes, and we very well know there are prothrombotic state which happens during the pregnancy and even in the postpartum. So when we need to consider an anticoagulation, we need to be very, very careful. that there are certain drugs which are definitely contraindicated, like DOAX or fondaparinux. At least they have not been found safe in pregnancy. So the only two major drugs which are definitely found safe are unfractionated heparin or low molecular weight heparin, and becomes main way of treating these patients, or main way of managing coagulation phase, especially patients ongoing on renal replacement therapy. So these are the two drugs. Vitamin K antagonist, again, warfarin-like drug has been tested only for valvular heart disease, but not been recommended routinely for these patients. So it's predominantly unfractionated heparin or a low molecular weight heparin. But at the same time, you need to understand that these anticoagulations are very much required for these patients, because they are almost always in a procoagulant phase. And it's not only the increase, the factors which are there, but also there is a decrease or reduction in the anticoagulation factors which are there in these patients. So a careful titration of these unfractionated heparin or low molecular weight heparin has to be done for these patients. And these are the only two drugs which have been tested and recommended for these patients. So finally, summarizing whatever evidence we have is a timing of renal replacement therapy early definitely may help, especially if you are looking at the fetal outcomes. And the timing is mostly dependent on whether we do use a conventional indicators like a rise in creatinine. But there is some evidence from the chronic kidney disease that higher intensity and early higher intensity and early start of initiation of these therapies in these patients may affect the perinatal outcomes, may not change the maternal outcome, but definitely may improve the perinatal outcome in these patients. The dosing frequency and higher dose, as I said, is better. Target parameters, we should not target bicarbonate of 25. It is acceptable to target between 20 to 22 in these patients. A sodium of 130 to 135 is acceptable for these patients, because these are the normal physiological changes which we see in a pregnant woman. Talking about anticoagulation, LMWH and unfractionated heparin both are safe during pregnancy. And again, one point which I missed in the presentation was about vascular catheters. As we know, the femoral is sometimes predominantly preferred site of placement, especially in an unstable patient. But here, because of a risk of postpartum hemorrhage, which is one of the most common reason, especially postpartum patient coming into acute kidney injury and coming into ICU. So a neck vein, which will be a preferable, especially the internal jugular vein, will be a preferred site of catheter in these patients, unlike in a non-pregnant woman where we may still